Hello, can you hear me?
Yes, sir, your voice is clear.
Oh, good morning, sir. Yeah, you
Um,
are audible.
Voice is okay, Sai, because I'm
Yeah,
trying
voice
different.
is, I think, yeah, it's good. Good.
Who is doing from Stockholm, Sai? No, you are going there.
I am going to the Stockholm, so I will
Okay,
present from there.
okay. I think
Yep.
Sunil is also coming.
Okay. I think we'll wait for another 5 minutes. As usual, nobody will be joining at 10. We'll wait for some more time.
The 80% in Stockholm can close the video, keep it front, so that once the Sai comes, I think you can try to, he can use it.
You can see only 4 or 5 delegates, sir. We will wait for 5 minutes, na?
Sure, Sai,
Sure.
wait, because
Okay.
usually around 20 people are coming. Huh?
Yeah, the average presence has been around 20-25. Once again, good morning all. We have close to 15 participants and it is 10:08. Another 2 minutes, sir.
Yeah, I'm okay, sir.
E-camera. So, welcome back. And today we have 3 talks as a part of the neonatal ventilation workshop for the Pedicon. As has been the case for the last 2 weeks, these online talks are going to be very important for our understanding on neonatal ventilation and will further be useful for all of us to interact on the hands-on workshop. Continuing from where we left yesterday, uh, the important aspect of neonatal ventilation is to optimize the ventilation practices to make it safe and effective. And today we are going to have a very, very important topic on pulmonary graphics. Graphics are very important to understand the baby and the ventilator interaction and optimize the ventilation settings and minimize the hazards. And to talk on this, we have Dr. Tejo. Dr. Tejopratap is a senior consultant neonatologist at Fernandez Hospital, Hyderabad. Someone coming with wealth of experience and immense interest in neonatal ventilation. He is the go-to person to understand the pulmonary graphics, and someone who has on multiple occasions taken a talk on this, and I'm sure he will simplify and put forward this very, very important topic to all of us. With that, I invite Dr. Tejo Pratap. Over to you, sir.
Thank you, sir. I'm just sharing the slide. Okay. Comfortable? Hello?
Yeah.
So you are
Your
able to see
screen
the slide?
your screen is visible and you're audible.
Sure. Okay. Yeah. Good morning, everyone. I think since last 1 week, intermittently, you are getting bombarded with the basics and then how to use ventilator. And then different modes have been covered yesterday in terms of hybrid and other things by Dr. Srirama. So I hope that you might have got some knowledge about initiation of the ventilation and how to use different modes. So right now, we know what is the indication for the ventilation, how it works, and what are the choices I have it. And then once the baby is on ventilator, how should I optimize the ventilation? And then last step we do it is that we want to make the baby out of ventilation, that is part as a wean. So to do these things, the main important thing is your monitoring and then optimizing your ventilation and then go about for the extubation later. So the pulmonary graphic will help you in many of these aspects of a ventilator. And we will also learn about what are the basics of graphics, how they get generated, and then few case scenarios where our pulmonary graphics will be important in terms of making the decision. So first, let's look at what is the need for the graphics. Okay. As I just told you right now, the aspects of ventilation, if you are doing in your NICU, covers in these 4 aspects. Okay. First thing is that whether my settings are correct or not. Second one is that whether after I initiated the baby on a ventilator with my settings, whether the baby is improving or not. So for that, you have some mechanisms like for the PIP, you will look at whether the chest rise is there or not. And then for the PEP, you look at the retractions, whether they are not or not. You look at the saturation. You look at many other aspects like whether the baby is comfortable on the ventilator. So all these aspects you wanted to do it. Then another important step in any ventilation is when I should make the baby out of ventilator. For that, you need to do a gradual weaning with scientific rationale so that you are not too faster to come out from the ventilator, which might potentially again cause reintubation, and then higher settings might be required because of the collapse and other things. And you are not disturbing the baby's physiological status also. At the same time, you are not doing it very slow weaning, where you are exposing the neonate for a prolonged stay on the ventilator, which might cause ventilation induced lung injury and its consequences, like both in the short term in terms of air leaks, inflammation, collapse, and other things, and then in the little short term and medium term, like pulmonary dysplasia and other chronic lung diseases, these children will be a little more exposed. So while doing these things, whether my settings are causing any complications in the baby, like if I kept the baby on a very high settings, the baby can go into a pneumothorax. Or sometimes accidentally ET tube might have come out. Whether I will be able to detect clinically in these case scenarios, what are my bedside tools which are available, like how you see the clinical examination, the chest auscultation, and then do the dope assessment, and then you can use the transillumination, other techniques to look for the pneumothorax. Another ornamentorium that you can have on the bedside is your pulmonary graphic. So while we are doing the ventilation, we keep the baby on at least these following settings. I just kept the FiO2 aside: PAP, PEEP, respiratory rate, inspiratory time, and the flow. And you wanted to see in the improvements whether the child is improving, especially in terms of respiratory mechanics, whether the compliance of the neonatal lung has improved compared to the deceased in the beginning, and also whether the resistance pattern is also improved or not. And I will also look for other complications like villi, air leaks, and any tube obstruction in the neonate while the baby is on a ventilator, to look for the weaning, whether first settings have requirement has come down, and also whether the baby is having a improvement in terms of a spontaneous effort. Thereby, you will be able to make a decision whether the child can be weaned off from the ventilator. How should we do it? So I discussed in the beginning, you have the clinical examination and some bedside tools like transillumination test and chest X-ray to look for the uh, good PP is delivered or not. All these things you have currently with the in your NSU. Can we use any other method to improve the ventilator optimization? So in the history, if you look at it, many of the medical inventions, when they have been percolated into the clinical practice, has made the life of a clinician very easier. At the same time, it also benefited the baby's outcome. One invention which has happened in the last 10 to 15 years is the very sophisticated flow sensors. Initially, we were having adult flow sensors which may not be able to detect properly the volume which we operate it at around 3 to 10 ml, and also the flows which we use it, very less flows, like even 5 to 6 liters, and change in the pressures in terms of around 1 centimeter. So these were very difficult previously. However, now with this very advanced sensor mechanisms which are available in this new novel flow sensors, are making our life easier to use this graphics in a much better way. With these flow sensors, now we are able to measure very small volumes and also low volume, and it's very easy to use also. You just need to do the initially calibration and then connect it and keep it a little clean. That should be more than enough for us to use while we are using it in the ventilator. One important thing that we should all remember is that these sensors are connected at the proximal end of your or above endotracheal tube adapter. So whatever that we will be talking in the pulmonary graphics is the changes which are occurring at these sensors will be converted into the graphical form. They are not classical representative of the things which are happening inside the lungs. Inside the lungs, something might be happening. However, because we do not have any sensor mechanisms currently to directly measure inside the lungs, we are extrapolating the data that is getting generated from these flow sensors into a pulmonary graph. So what we do now? So from the initial fortlet, we wanted to see these methods, whether my flow, which I have kept it, is getting delivered to the baby or not, pressure, whether it is getting delivered to or not, time. How much inspiratory time I have kept it, whether it is getting delivered to the baby or not. Our ventilator sensor can only measure these three. All the other things like volume and any other uh, parameters that you are seeing, like minute ventilation and other things, are just extrapolated from these three basic parameters. So machine also calculate the compliance based on this resistance and the volume that is generated. And of course, we look at the workability manual clinically also. Machine also tells you that whether the mode that you are getting, that you have kept it is, whether it is working or not. While we are doing the monitoring, we look for the saturation, retraction, and the respiratory rate. Retractions includes your objective measurement of things like Silverman scoring and Downey scoring, or you can just clinically look at the retractions and then say that whether the distress is improving or not. We will also look for some of the misadventures while the baby is on a ventilator. What we have discussed so far: air leaks, air trapping, obstruction, secretion, and the work operative. With the graphics, we can make use of new technology which will try to help in looking at all these aspects of the ventilation. Thereby, you can do the optimization and benefit the baby in terms of reduction of the ventilate ventilation duration, and also the decrease in the misadventures that are happening. So what are the graphics currently we have? The graphics are divided mainly into two types. One is a scalar graphic, second one is a loop graphic. The scalar graphic means they are plotted against the time. So different parameters, pressure, flow, volume, are plotted against the time. That means that in a breath cycle, while it is going on the from 0 to next second, how these three changes are happening. And loop will look at the parallel changes that are happening between the pressure and volume, and also flow versus volume. Pressure versus flow also some people use it, but in neonatology we use currently only these two techniques. So scalar graphics are plotted against the time. For understanding sake, we will next in the few slides, we will demonstrate you how any mechanical breath will look like. So as I said, parameters are plotted against time. So suppose if you want to look at pressure versus time graph, that means that P will be on your y-axis and time will be there on your x-axis. So what are the things that will happen? So while the baby takes any inspiration from the pre-existing pressure that is inside, so the initial pressure that will be there throughout the respiratory cycle is your PEEP. So whenever a breath is getting delivered, the additional pressure will get generated and it will reach its peak point based on our setting. It will stay till the duration that we kept it as an inspiratory time, and then it will come back to PEEP once again, so that that inspiratory cycle of the respiratory breath that is getting generated by the machine is completed, and then PEEP will be there throughout the expiratory cycle, because this will try to prevent the baby having any collapse. So then again one more breath will get generated, and then it will again stay back till the inspiration, and then you will have a expiratory breath, the expiration which will get started in that respiratory cycle, and the child will be on the PEEP. This is how typically your pressure versus time curve will be there. So next is your volume versus time. So in here again, time will be there on your x-axis, volume will be there on your y-axis. So what happens here? Do we have anything that volume that will be there inside that we will be able to measure? We will not be able to do it, because we are just looking at the changes that are happening at your ET adapter level. So we will only be able to see how much volume that is going inside and how much volume that is coming outside. The volume will keep going inside during the inspiration, and the volume keep coming outside during the expiration. So this is how it will appear on your pulmonary graphic. So the scalar graphics, as we discussed, first one is the pressure versus time. I have shown you in the previous slide while I was drawing it. So this is how it will appear on the pressure versus time. So this is the peak inspiratory pressure that will measure, and it could be a set pressure in a pressure control mode, and then PEEP, which we keep it. So that will be there throughout the respiratory cycle. That is the peak and expiratory pressure. The PIP will be delivered only during your inspiration. The PEEP alone will be there during the expiration. Flow versus time, if you look at it, initially the flow will keep increasing till we reach to peak inspiratory pressure. Then it will get plateaued up and it will go to zero once you have reached the desired pressure. Then again, the negative flow will keep happening to vent out that pressure from the lungs into the atmosphere. So that is the negative flow will be there during your expiration. So the positive flow will be seen in your inspiratory time, while negative flow will be seen in your expiratory time. So then another breath cycle will be represented in a similar manner. Volume versus time, as I said, initially the volume will keep increasing it, and then it will come to zero at the volume whichever you have pushed inside, that will come back and will touch the zero at your ETR level. The first half, while it is increasing your inspiratory time, and while it is coming out, is your expiratory time. So the peak volume that has gone inside is your tidal volume. This is what we need to remember while we are reading any scalar graphic. The next one is your loops. In the loops, as I said, there are three types of loops, which are pressure versus volume, flow versus volume, and flow versus pressure. Currently, we are using these two only in the neonatal period. So in the pressure versus volume loop, how it will appear? The pressure will be there on your y-axis, volume will be there on your x-axis. Yeah, this can be different in each ventilator. So sometimes pressure will be there on x-axis, and then on the y-axis you can have the volume. So keep looking into your ventilator whether whatever that you are interpreting it is actually based on the ventilator also is looking at it similarly. So during inspiration, the pressure will start increasing in the mechanical breath. So initially, it will start increasing it, and simultaneously the volume also will increase, and then during expiration, the volume is coming back, and pressure is also getting decreased. Suppose if you had a PEEP on the same, the curve will start from here to here and then come back here to here. So this is how your pressure versus volume loop will appear. So we will look at following things. What is normal in the pressure volume loop? How it will changes in these different type of settings. Like if you are giving excessive PAP, or whether I am giving optimal PEEP or not. Am I not looking at the inadvertent PEEP that is getting generated because of the excessive flow? Is the compliance in the unit has improved or not? And whether the flow settings which we have kept, is it correct or not? And whether the baby is spontaneously breathing or not. So these are all the things that you can be able to see. So typically, the pressure versus volume loop will appear like this, as I explained to you in the beginning. So what are these? If you divide it into two halves, the first half is your inspiration. During the inspiration, as the pressure is changing, the volume that is getting delivered into the lung is increasing it. It will reach the peak, and then it will go back to the original status of the pressure during the expiration, because the volume is coming out and pressure is also decreasing inside the lung. So how does our PV loop will help us in assessing the workup? So you can divide the workup breathing into two aspects. So first one is the A, that is resistive workup breathing. Second one is the B, which is the elastic workup breathing. Resistive workup breathing is nothing but the resistance offered by the interstitial tissues while you are pushing the gas into the lung. That is the inspiratory workup breathing. While there is a elastic recoiling which is happening, how much is the energy that is movement? That is your elastic workup breathing. We should also look at some other aspect in the PV loop is inflection point. You have two inflection points. One is the lower and second one is the upper inflection point. So the lower inflection point will guide us to optimize the P. So if the lower inflection point is too far from the zero or from the beginning of the pressure volume loop, that means that we are not giving the adequate peep to that peep. If it is very near to the, if it is near to the origin of this loop, that means that you are giving a good peep. So why it is important? Suppose you have a curve like this versus you have a curve. So your lower inflection point is here, whereas your lower inflection point is here. So what is happening here? The initial pressures are getting just wasted here to improve the compliance. So we know that the compliance will be very good once the child attains the FRC, that is the functional residual capacity, from where you will have the delta V by delta P, which will be much better. So what is happening here, delta V by delta P, if you look at it in this curve versus in this curve. For each increment in the pressure, the volume increment is very smaller here, whereas here it is much better. In this way, it will try to help you to optimize your PEP. What is the upper inflection point? What is happening here? Again, here, if it is too far, that means that maybe we are giving excessive peak inspiratory pressure for that baby. So once you add the PEEP into the PV loop, it will start from the baseline from a distance from the 0 point on the x-axis. This is how it will appear if you are adding the PEEP to the baby. When you are using very excessive PAP, how does we know it from a PV loop? As I explained in the previous graph, the delta V by delta P is good once the FRC is reached. At the same time, once your tidal volume is reached, reasonable tidal volume, the additional volume that is getting generated in this lung with this much increase in the additional PIP is very minimal. Whereas here, if you look at it, it is very good. Whereas here, for each increase, you are having only this much, only this much increase in the delta. So that means that this additional pressure is not contributing anything to the tidal volume. So we can cut down on this PAP, thereby reducing the barotrauma in the neonate. And this is called as a beaking in the PV loop. So whenever you are seeing excessive beaking, then you should look at what is happening in this pressure. Can I reduce it? Another parameter that is calculated by the ventilator is the C20 by C. That also you can try to use it for reducing the PAP. So this C20 means the last 20% of the breath. How is the compliance compared to the overall compliance? If it is too low, that means that it is not good for the baby. So additional pressure, you can try to reduce it. What happens with the effect of surfactant to the PV loop? So why we use the surfactant? It is just to improve the compliance. So compliance improves means the delta V by delta P should improve, isn't it? So that means that for each additional pressure, additional volume should increase. That means that graph should move towards this, thereby the compliance can be looked at it. Okay, so this is how it will move. So once the compliance is improving, then your loop is moving towards the left. If the compliance is reducing, then it is going towards your x-axis. The same thing you can look at it whether your PEEP and disease process, whether your PEEP is improving in the compliance or whether your disease process is decreasing and improving the compliance by just looking at the graph. So if the graph is moving towards the left, that means that the compliance is improving. If the graph is moving towards the right, definitely the compliance is decreasing. Okay. We can also look at inadvertent PEEP generation and also high flows. As I told, that graphics will try to help you out. You have set the PEEP here, but in the subsequent graphics, you are seeing that the PEEP is getting generated more. And your loop is moving on the x-axis towards the right side. So that means that some auto PEEP is getting generated. So please look at what is happening there. Is it the obstruction or high flows that you are giving, which is causing this problem to the baby? If you have very limited flow that you are giving, the baby can have gasping in between. That is shown like a cooped appearance or gasp appearance when it is there. Or your loop might get shrunken a little compared to the loop that is getting generated with the adequate flow. So these two graphics will try to help you on how it is, whether the flow is adequate or not. In extreme forms of air hunger, especially in the neurological cases or severe acidotic breathing, you can see this 8 appearance on the PV loop. That means that the baby is gasping a lot. Please look at other aspects in this baby for optimizing the ventilator. After learning about these aspects of the PV loop, now we will move to flow volume. In the flow volume loop, we will also look similar things like normal, abnormal things like tube leakage, air trapping, increase the resistance for the expiration, and some secretion. These are the 4 classical things that can be picked up on the flow versus volume loop curve. So the typical appearance of the flow versus volume loop will be like this. Maybe you might have seen this elsewhere also, like in a child with asthma, you might have assessed the peak expiratory flow rate with one machine, and that will also appear in the similar way where they will try to use the flow volume curve only in that scenario also. So what is happening here? The flow is on the y-axis, on the x-axis we have the volume. There is positive and negative flow that will happen. So initially the positive flow will keep increasing it till your PAP is reached. PAP will be there till the set TI or your volume is reached, and then the negative flow will start, and then that will go into expiration. This is inspiration, and this is your expiration. That is the peak inspiratory flow rate, and this is the peak expiratory flow rate each baby is generating. And this is the tidal volume that has gone inside the baseline. We usually assume that we are starting at the functional residual capacity. Let's see how flow volume versus loop will help us in different other conditions. So the normal flow volume loop will be like this. In a case where there is an air leak, you are seeing that there is a movement here. There is a gap here. What is this gap? Why this gap has happened? During inspiration, the flow is going well and the volume is getting generated. But whole volume is not coming back to the adapter. That's the reason why that gap is there, which is showing you that there is an air leak. Suppose you have a air trapping, then what happens? The flow, the volume will not come to zero at all. So this is all air trapped volume that is there inside the lungs. If there is an increased resistance, how does it look? Obviously, it is called as a scooped out appearance. So initial curve is like this. It is going lower. Your PEFR is getting low. What happens typically in asthma? We know that the resistance will increase. Similarly, in the flow volume loop, when the airway resistance increases, it will go inside. The peak expiratory flow rate will decrease. Okay. If you have a secretion, then it will appear like this zigzag manner in the expression. Okay. During inspiration, usually they will not get affected much, but during expiration, they get affected a lot. That's the reason why this zigzag pattern will be there, because expiration is the elastic recoiling which is happening, whereas here inspiration is the flow at a high rate which is going, that will be able to overcome the resistance that is offered by the secretion. Okay. Suppose you have an obstruction, how does it will appear on the flow versus volume loop? So what will happen? Obstruction. Obviously, the flow will decrease, and also both the PIFR and the PEFR will get reduced here. So that's the reason why your hysteresis has shrunken here. The loop has shrunken here. If it is an extrathoracic obstruction that is happening, what will happen extrathoracic obstruction? During inspiration, usually because there is a high pressure and high flow that is going inside, there will be a little lift of the trachea so that you will be able to generate that much reasonable good flow. However, during expiration, because the flow has to come from the lung to the outside, your PEFR is compromised significantly, and it will appear like a cigar appearance or something like that. Okay. If it is an intrathoracic obstruction, like typically a trichomalacia, once again, what will happen? Again, during inspiration, the flow is good. It will try to lift the weak tracheal muscle, trachea that is there, tracheal cartilage. However, during expiration, once the inspiration is getting stopped, it will collapse. During expiration, it will offer a little rot of resistance. Thereby, you will not be able to get the good flow pattern if there is a tracheomalacia or some stenosis, or sometimes you might have the granuloma and other which might be there. These appear like this pattern. Okay. In severe tracheomalacia, sometimes you may not be having, you need to keep a lot of pressure to just dilate it. So that's the reason why you might get some wavy pattern even during the inspiration. Okay. Look at the flow that is there in the first loop. It is a 3 liter flow. So that's the reason why you are having hysteresis which is smaller. If you keep the flow a little good, both your volume generated and your PAFR and the PEFR has increased. So this is how it will appear on your flow versus volume loops. Let's look at typically different case scenarios and how our loop graphics and the scalar graphics will try to help us in these conditions. So first case is the Ehrlich syndrome. What is happening in this flow versus time graph? Okay. So what should have happened? It should have stopped here, but there is something that is happening here. Additional flow is getting required, positive flow is getting required to keep the PEEP inside the baby. So this is all is the air leak which is there inside the baby, might be due to small tube or tube that might have come out. PV loop, how it will appear? Initial PV loop, you know that this is how it will appear. So initially the inspiration is going very nicely, but during expiration, just follow that purple line. It is not coming back to the initial point. So that means that much volume is getting lost. So this is all your air leak once again. The volume loss which has happened. In volume versus time curve, what will happen? It won't come to 0. And this is the air leak that has happened. That much volume has been lost. So you can use different curves, different graphics, both the scalar and your loops to look at it. So classical flow versus volume loop, as I have shown you previously. So this is your air leak that is there, and that is the volume loss which is there in the baby. How air trapping will? So we know that this is a flow versus time curve. If there is a air trapping which is happening, that means that the flow will not come back to 0 because the trapping has happened. And this much trapped flow is inside. That's the reason why it is not coming back to 0. This is your air trap in the flow versus time. If it is in the flow versus volume loop, again, it will appear like this. And this much is your air trap. In the PV loop, what should happen? If there is a air trapping, it will be shown as an inadvertent PEEP generation. So your graphic will move towards the right. So this is how it will appear for on your graphic. So baseline graphic, you can store it and then see how it is moving in front. Okay. You can also will be able to look at and diagnose whether the baby is having a spontaneous breathing or it's a machine breath. How many are the spontaneous breath the baby is having it? In a PV loop, spontaneous breath will look differently compared to the typical PV loop of a machine breath. This is a controlled breath. Suppose it's an assisted breath or a triggered breath. So what you have seen here is that initially there will be a little negative pressure which has generated, and that's the reason why this tail is there. So this is an assisted breath. Okay. If just based on this tail, you will be able to see whether your trigger is good or not. If your the tail is very long, that means that you have kept the trigger at very high level and it is very inadequate sensitivity. You kept the trigger at very inadequate sensitivity. It can increase the work of breathing. Please look at that baby once again. In a spontaneous breath, it will appear like a figure which is there vertical. Okay, because the baby will be having the breathing like this, the spontaneous breath. Cycling, we know that 2 types of cycling, yesterday also discussed, time cycle and the flow cycle. Major difference you can observe in this first graphic versus the second graphic. There is no gap here. Why it has disappeared? In the time cycle, what happened here? The flow has increased. Once the desired limit or control is reached, it has come back to 0. Because the baby's inspiratory time has been not completed as we kept it, there is a gap before it can go into next phase of respiratory cycle. So this is the inspiratory hold that will be there in your time cycle ventilation. In a flow cycle ventilation, you will not be seeing that inspiratory hold. How it will appear on the pressure time curve? In the first two graphics, you can see the plateau is very longer here, whereas here it is very low. Because there is no inspiratory hold here, in the flow cycle graphic, you are not seeing that plateau longer. What is the ultimate thing that is happening here? The curve of a respiratory cycle or the area under the curve of a respiratory cycle is lesser. Thereby, you are reducing the map. Area in each breath in the PT is your map. Basically, you are reducing the exposure to higher maps if you are using the flow cycle. That is why it is called as more physiological ventilation. How it will appear on the volume? Again, the plateau of the volume will not be there while you are using the flow cycle ventilation. Okay. This is the inspiratory hold that you usually see on your volume ventilation with the time cycle. Volume ventilation with the flow cycle, you will not have that plateau because once the tidal volume is reached, it will go to expansion. Modes, once again. So here you are seeing that what is happening, all are uniform and all breaths are similar. However, there is a little difference in the volume generated in each breath. This is how a typical assist control mode will appear. If you keenly observe, there is a little variation in the TIs here, sorry, TEs, because you are allowing the baby with a backup respiratory rate only in the assist control mode. And when the baby wants to take the breath, you are just supporting all the breaths in the assist control mode. Okay, so you can see that the volume is different and there is a little variation in the inspiratory time. If it is a SIMB mode, what is happening here? Some of the breaths are spontaneous breaths and some of the breaths are machine breaths. If the baby wants to take more than the breath that you have set in the SIMB mode. The sky blue color, which is represented on the pressure versus time curve, is a spontaneous breath. Whereas the thick blue, which you are seeing, is the mechanical breath. So all the three parameters, both the pressure, flow, and the volume generated is different in these three in these breaths compared to the machine breath. So that is how you will be able to see it. Suppose if you add the pressure support, there is a little fixed pressure support that is getting assisted for all the breath, all the additional breath the baby wants to take. So these are the pressure support breaths which you are giving it. Suppose you add volume guarantee. What is happening here? Just look at the graph on the volume versus time. Almost consistent volume is getting generated. Whereas if you look at pressure during each breath that is getting delivered, it's varying. Why it is happening? Because you have added the volume there. So once the baby reaches the set tidal volume in that breath, the additional pressure will not be delivered. So this is the beauty of the volume guarantee ventilation if you are giving it to the neonate, thereby reducing your total exposure to different higher maps. At the same time, consistent volume that is getting delivered, so your volume also will get reduced. This is the additional PAP that is you are reducing it. Otherwise, you might have exposed that baby a little higher PAP. What are the other uses that we wanted to look at it. In this. What happened here compared to here? So baby wanted to take a breath here, but it was not supported. So in the initial graphic, you have seen only a mechanical breath. Suppose if we have a trigger which is good, then it could have delivered a complete breath. What happened in this graphic now? There is double inspiratory cycles which are there. It is due to a double trigger. Might be due to your water which is there in the circuit, or baby is having too rapid respiratory rate. That's the reason why you're having the double trigger here. Graphic will also help you to choose the ideal TA. What is the ideal TA among these three? Obviously the center one. Why I am saying it? Because once the inspiration has stopped, immediately the expiration is stopping. What is happening in the first? The inspiratory flow has not come to zero and the expiration has started. What is happening in the third? Inspiratory flow has come to zero, but the expiration is not getting started. So this is normal. Here it is very shorter. Here it is very longer. So you will be able to choose the ideal TA, near ideal TA we can say, or optimal TA for that baby if you are using the these type of graphics. Then again, sine wave pattern and square wave pattern. Nowadays, the options are not available in majority of the ventilator, but if you are still using the older ventilators or some of the Mackett and other things, there will be option called sine wave versus square wave. Sine wave will appear like a fish, what do you call it? Tail pattern here, and then square wave will be square. So the advantage of square wave is that it will generate a little more map. Sine wave is generate a little lesser map. However, because usually the breath will happen like this only. So it won't go to PIP immediately in the physiological breath. So that's the reason why people will prefer a sine wave over the square wave because it is more physiological. But when you are having very high severe lung disease, maybe you can choose a square wave pattern so that it will be able to generate more map. Okay. So let's see other uses also. This is a typical scalar of a assist control. You have acute deterioration. What is happening here? There is a air leak which has happened. All the pressures, flow, and the volume have come down. So that means that there is a problem either with the equipment or there is a circuit leak that has happened. Now look at this acute deterioration case. The pressure is getting delivered properly. Flow is not getting delivered and the volume is not getting delivered. What happened here? That means that something is obstructing the flow. So it could be a completely blocked TTT or very severely bad lung with a very low compliance or high collapse that might have been there. Some other case scenarios also, let's see. So initially you have a baby on day 2 on PIP of 30. Look at this, what happened? It has ballooned up. And by day 18 and your pressure has increased. So initial balloon has happened mainly this side. Now it has started to happen on the even on the elastic recoiling. So something is happening on this. Probably there is a both worsening compliance and resistance. Typically, it might happen in bronchopulmonary dysplasia. Suppose if you have a baby PV loop from the day one, if the baby is on a ventilator, we do not want the baby to be ventilated for 28 days. However, if you have the initial graphic, maybe you'll be able to compare when the baby goes into a BPD. We can even predict a little early only if the PV loop is increasing on both the sides. That means that this child might be at very high risk of BPD. Look at this case scenario. What happened here? very chaotic. If you look at the scalar graphics and then compare it with the loop graphics, what is happening? Your pressure, this is the pressure, this is the flow, and this is the volume. Starting, but it is not sustained. Here also, flow is getting started, but it is not sustained. Pressure, it is getting started, it is not sustained. In the flow versus volume loop, you can see flow is going started, but it has not touched anything. So here also, pressure has started to increase, but nothing is getting generated in terms of volume, or it is not coming back. We do not want these misadventures to happen in your unit, but graphics do help you. So it might have been due to accidental extubation. That's the reason why nothing is coming back from your ET. So please look at it when you have these sort of appearance. So what did you learn today? First thing is that we can learn a lot by just observing the graphics. It will definitely complement, may not replace, but at least help us in replacing to an extent or reducing our more number of ABGs, and also it will try to help you to correlate your vital monitoring signs with the baby. It will help in converting our good judgment to informed judgment. So that's a very good uh, clinical armamentarium for us, because the good judgment will come with a lot of experience. However, we cannot make the babies to suffer when we are underexperienced. But definitely these type of armamentarium will help you to take the decisions with more good, more better judgments rather than the low borderline judgment which we want to take. And underline bottom line for all these sort of new things is that eyes can see what the mind knows. Mind should know what and where to look for with us. So this we should never forget it. Only if you know how a normal graphic look and in different abnormalities how it will look at it, and if you periodically look at the graphics, then only you will be able to use it with more confidence. We know that now at different places these graphics are getting used, movies, gaming, and even in the games also they are getting used. Okay. We are lag behind it to a certain extent. Definitely we should start using it. Thank you once again for patient listening. If you have any questions, I will be able to, I will try to answer some of it. Yes, I am ready.
Thank you very much, Dr. Tejo, once again for presenting such a complex topic in a very lucid way and help us understand. I think I think I agree with you completely that it's a bedside armamentarium which makes our judgment from a good to an informed judgment. That was very nice. Any queries, please feel free to ask. And this, when we are, my query would be that when we are using these graphics, especially when you're talking about the scalars and this, what is that one graph which you advise us to look all the time when we are bedside?
I think
Because we
maybe
see so many on display, always get confused. If there
I
is one
know.
graph I have to see, sir.
So I think in the initial phase, the PV loop will
Okay.
be of good importance, because you will be able to judge whether the compliance is getting improved with your setting. Second one is that it will try to help you in looking at the settings, both the PEP and the PAP, and it will try to help you to choose the better PAP and better PEEP for that baby in the initial part. And especially we look at premature baby and other babies where the ventilation requirements have gone. Still requirement is there. Most of the term babies we are able to extubate with a short duration ventilation now. So in the initial part, I think first 3 days, the PV loop will be of good importance. Later on, I think we should also look at the flow volume loop. If you want to look at only one thing, obviously. Obviously, we need to look at multiple things, but flow volume is the other thing, because there you will have more of the issue with the obstruction, accidental extubation, and tube movement that is happening, and the secretions which are happening. So this all will be can be taken care in a better manner if you use the flow volume.
I agree with you that if there is one graph which has a lot of importance for all of us to at least master and understand is the PV loop, and thereafter, of course, the flow volume also. So I think it looks easy, but I think that's how when we practice and the more and more we see on our machines bedside and apply it to the baby's pathophysiology, the better we learn. Once again, thank you, sir. And again, we will have an interaction with Dr. Tejo in the hands-on workshop where we can clear our doubts on the pulmonary graphics. Thank you, sir.
Thank you. If there are no doubts, I think I'll.
Yeah, I think I checked there are no queries.
Okay. Okay.
So with that, we move on to the second talk. Maybe while Dr. Zaki joins us, you can all stretch yourself. The next topic is on high frequency ventilation, and a very difficult topic to understand sometimes, that at least how it works and when to apply, how to apply, and which all machines we have, and what is the technology behind them. Are they similar or different? To make us understand on this, I invite Dr. Zakiulla. He is a consultant neonatologist at Fernandez Hospital, Hyderabad, and someone with keen interest, a young gun who has a lot of recent updates with him. I welcome Dr. Zaki. Over to you, Dr. Zaki.
Hello. Yeah, thank you, sir, for the nice introduction. So, I think I can start, right? I will share the screen and then.
Yeah, please, you can share the screen, unmute. You are audible, but your camera is not on.
Okay, okay.
So your presentation slide is at monitoring.
Audio.
If your camera can be switched on, if it's comfortable for you, Zaki, so that audience can see you.
Yeah,
It says right now.
Am I visible? I think it's on.
Yeah, it's visible. Yeah, it's visible.
Yeah, now I can see. Now I can see. I minimized it. Thank you. Over to you, Dr.
Yeah.
Zaki. Over to you.
Okay. So, yeah, hi everyone. Good morning. So we'll discuss about high frequency ventilation and last few slides about inhaled nitric oxide. So just if I am in a hurry, just please stop and then ask me, because it's a difficult topic to understand. If you have any queries, please feel free to stop and then ask questions. Okay, don't hesitate. And if I'm too fast, also just ask and then tell me to go slow. Then I will proceed with that. Okay. So I think everything we have discussed about conventional ventilation so far. The next topic will be about high frequency ventilation. So next few slides, my objectives will be, so why high frequency oscillatory ventilation? What is the advantages? Already we have so many modes in the conventional ventilation, so many like newer modes, hybrid modes, and then we have volume targeted ventilation. So despite that, why we are using high frequency oscillatory ventilation, and then how it is different from the conventional ventilation with respect to its gaseous exchange, mechanism of action, how it is different. And then we'll discuss simultaneously about the mechanism of gas exchange in high frequency ventilation, and then how to apply it in our daily clinical practice. Each parameter, how to set, how to titrate, and then how to decide like what parameter, how much to set each parameter, and then what is the rationale behind that. And then just last we'll discuss about the what is the evidence so far of high frequency ventilation, and then finally we'll discuss about the inhaled nitric oxide use in neonates. So basically, what is HFO, high frequency, why it has come, like what is the main worry with this conventional ventilation is obviously like ventilatory associated lung injury. So valley. So that's the main concept. Like, because initially we used to aggressive ventilate all the babies. Then lot of babies with BPD, and then gradually came non-invasive ventilation, and then that has increased your old BPD, and then now lot of new BPD we are seeing. But the main culprit of side effect of this conventional ventilation is uh, ventilator associated lung injury. So any baby with this on mechanical ventilation, out of the what are the various methods by which it will cause lung injury. So most important one is the value trauma. So previously, initially people used to think barotrauma, but now it is proven that pressure doesn't cause the lung injury. It is always that value trauma. Many experiments are also been done where they have restricted the thoracic cage. They have given high pressure without change in the volume. So then, despite giving high pressure, but if the volume is normal, then it didn't cause any injury to the lung. So it is always value trauma. And then one more thing is atelective trauma. So when there is swing in these pressures, if you're not giving adequate pressure, if the lungs are not adequately recruited, or if their lungs are recruited during the inspiration, but during the expiration, again, they are collapse. So this will cause atelective trauma if you're not giving, if you don't recruit the lung appropriately. So this value trauma and then atelective trauma, this will cause a lot of shear stress and then activate the inflammation, and then it will cause biotrauma, which ultimately leads to ventilatory associated lung injury. Because of this ventilatory, once maybe on ventilation, you are, but if you are not doing it properly without with not in a lung protective, probably we'll discuss in the subsequent next topic on the lung protective ventilation. But if you don't take care of the lung, then it will cause lung injury, and it will worsen the lung compliance and also worsen your gas exchange under the lung. So because of which, again, you have to go back and increase the setting, give more volume, and then which ultimately will cause more value trauma and then more atelective trauma. So, but in addition to this, it will also cause inflammatory response, which leads to edema and non-homogeneous lung aeration. And also because this inflammatory response, it will cause both lung injury and also systemic inflammation will lead to in premature babies reopening or worsening of the PDA, which again worsen your compliance gas, and also it might cause hemodynamic instability. And also it might cause multi-organ dysfunction if it is severe inflammation with severe PDA. So because of this concept, like a lot of trials are also done comparing volume targeted ventilation versus pressure limited ventilation, where they have seen that once you target the volume to, here we are targeting the targeting volumes around 5 ml per kg, depending on the underlying lung disease. But if you target those volumes, then you have seen there is significant reduction in incidence of BPD. So they have included almost systemic review in Cochrane 2017 on 60 parallel studies, so then including 4 crossover studies, which have shown that if you target the volume, and then incidence of you can chance of BPD reduction by almost 27%, and then number of neutrals treat is 8. In addition to the reduction in incidence of BPD, there are also benefits like grade 3 PVL, grade 3 and 4 severe IVH, grade 3 PVL, hypocapnia incidence are less in babies who are targeted ventilation was done, and also incidence of pneumothorax, and then the number of days babies on respiratory support requiring mechanical ventilation is also less. So there is always, we know that like volume target is ideal mode if you are giving conventional ventilation, but depending on the baby's condition, again you have to decide. But here in HFO, high frequency, what is HFO? What you are giving here in high frequency ventilation? So here, basic concept is two things. One is you are giving very small tidal volume, so you are using less than the dead space. So we have seen that based on the systemic review, if you target the tidal volume to 4 to 5 ml per kg, then babies will have significant benefit. So, but in high frequency, we are using less than the tidal volume, like minimal, very small tidal volume, that also less than dead space. That is around 1.5 to 2 ml per kg, which we are using. And also we'll use very high rates. So normally we use around 10 to 15 frequency. That means for every 60 breaths per second. So here, if you 10 means almost 600 breaths per minute. So that's a normal, but sometimes depending on underlying lung disease, you might use frequency of 8 also, that around 500. But so here basic concept is you are using very high rates and then very small tidal volumes. This will avoid your value trauma, which has already proven from the previous Cochrane reviews, systemic reviews. And in addition to that, you are giving delivers continuous map and avoid the pressure swings. Too much of pressure swings which you are doing in conventional ventilation, that you are avoiding here, but you are continuously giving mean airway pressures, and this will avoid your atelectative trauma, which are two most important components of your ventilatory associated lung injury. So those two things we are taking care of in high frequency oscillatory ventilation. So basic design, how it works. This is like basic design of sensor medicine, but now a lot of ventilators are available, different ventilators with different mechanism. So here what you can see is that one piston. So one ventilator apparatus will give the continuous map mean airway pressure, that is nothing but the end expiratory pressure for the alveolar recruitment, and then for lung expansion, and then on top of that you are using this piston pump to push the air into the respiratory tract. So here this forward motion will push the air into the respiratory tract, and then your backward motion will pull it out. So here both inspiration and expiration are both are active. It is controlled by the piston pump. But now other ventilators are using different mechanism, like they're using diaphragm, and then by dragger, and then they'll use reverse jet in the SLE ventilator. But here overall mechanism is that you're pushing it forward by using the piston pump. Then here, that how much you will push distance, that will determine your amplitude, how much depth you will push, and then how much you will retract. That will define your amplitude, and how much time it will take to push it forward, that is the inspiratory time. And then the time it takes to push backward, that is the expiratory time. Inspiratory and expiratory time, and then amplitude will be determined by this piston pump, how deep it is pushing, and also how much time it is taking to do this movements. And in addition to that, you will set FiO2 and then mean airway pressure. And then here in high frequency ventilator, the bias flow which you are using is also very high. Like conventional ventilation, you will use 10 to 12 liters, but here you have to use very high bias flow, around 30 to 40 liters per minute. So you should have that proper humidification whenever you are giving high frequency ventilation. This is the basic design of the ventilator, and then we'll just see how the mechanism of gas mixing in this high frequency ventilator. So basically, for conventional ventilation, the basic mechanism is, one is convection. The gas is moving from one end to the other end towards the alveoli, and then at some point there is both convection and diffusion which is happening, but predominantly it is the diffusion which is happening at the level of alveoli in the conventional ventilation. Those there in the alveoli, based on the concentration difference, the gases will exchange oxygen from the alveoli into the bloodstream, and then from the bloodstream CO2 will exchange into the alveoli, and then through the convection it will go out. This is the basic concept of the conventional ventilation. But here, in addition to these mechanisms, in high frequency ventilation, there are other mechanisms which will operate in high frequency ventilation. So of these most important mechanisms are, one is Taylor dispersion, and then asymmetric velocity profiles, which we will see. So here what piston is doing, it is pushing air through the piston pump, a rapid jet of air with very high frequency. So this air, so this we will discuss in the subsequent slides about the Taylor dispersion, asymmetric velocity profile, how it will benefit, how it will involve in the gas exchange. In addition to these two mechanisms, one more is a pendulum mechanism. So here there is, because of this variable time constant or variable, some alveoli will be collapsed, some alveoli will be open. So there will be movement of gas from one alveoli to the other alveoli because of this variable time constant. So that will help in the gases exchange. And one more is this turbulence of the gas which is happening in the major airways. And also there is collateral ventilation. There will be there are like connections in between the alveoli, ports of cone, and then Limburger. So these will help in the collateral ventilation. In addition to that, because of this cardiac contractility, there will be cardiogenic mixing surrounding that cardiac contract. Because of this cardiac contractility, there will be better gases exchange around this area which is surrounding this cardiac heart. And in addition to these mechanisms, so one is these two most important mechanisms, Taylor dispersion, and then the asymmetric velocity profile, the coaxial flow which is there in this high frequency ventilation. So here what will happen, whenever you are pushing the air through the piston, there will be like the central core of air which is moving rapidly compared to the peripheral air, periphery to the central core. So here whatever is air pushing the oxygenated air, it is going through the center of the core of the airways, rapid jet, and then the expiratory air is going through the periphery of this rapid jet, surrounding this rapid jet. So there will be, because of this oscillation and friction, oscillation of this piston pump, there will be a lot of gas exchange which will happening through this direct bidirectional flow. Diurnal expansion, oscillation of this, and also as because of the similar mechanism, there is bidirectional flow of the gas. The central core of the oxygenated air will go through the core of the airway, major airways, and then there will be like peripheral of the airway going outwards. So this is the expiratory gas which is going outwards. So these two mechanisms, in addition to the other mechanism which we have discussed in the previous slides, will play major part in the gas exchange mechanism. So basically, gas exchange in HFO, it shifts the transition point between the convective and diffusive gas transport progressively in a cephalad direction from the acinuts into the larger airways. So in conventional ventilation, gas is mainly happening in the acinus, but here in high frequency ventilation, gas exchange happens even in the acinus and also even in the larger airways. So that's why like more areas involved, so there is better efficient CO2 elimination relatively independent of the mean lung volume. So though we are giving very small minimal tidal volume, but gas exchange is happening throughout the even the larger airways. So that's why there is better CO2 elimination, which can be explained by this high frequency ventilation. So what are the various parameters which you will set on high frequency ventilation? So one is for oxygenations, you will set MAP, mean airway pressure, and the FiO2. And then for ventilation, you will check amplitude and frequency, and then I ratio will involve. So usually keep it standard. We don't touch. Usually we'll start with 1:2, unless baby is having severe disease where you want to have better ventilation, better recruitment. Then you might decrease the I ratio to 1:1. But usual norm is we'll start with 1:2 in all the babies. So other settings which we'll touch is again amplitude, frequency for ventilation, and then for oxygenation we'll use mean airway pressure and FiO2. So we'll discuss each parameter, how it operates, and then how to decide initiate and how is different from the conventional ventilation. So in conventional ventilation, what will happen? So when when babies having either heterogeneous lung disease or whenever you're giving a PAP of suppose like 20 or 5, so during inspiration lungs are alveolar expanded, but during expiration they will again they will go back, size will decrease. But sometimes if you're giving adequate PEEP, they will able to keep open. But if the PEEP is not adequate, then sometimes they might collapse. Or some areas of the lungs where delivery of PEEP might not be adequate, so alveoli might collapse during the expiration. But in some areas of the lungs where delivered PAP might not be sufficient, there might be collapse of the alveoli both during inspiration and expiration in conventional ventilation, because you are using that gradient of PAP and P. But in high frequency ventilation, you will give continuous map of depending on the underlying lung disease or whether you are using the primary mode or rescue mode, whatever pressures you have generated, then once alveolar recruited, then you will give that continuous map. So there won't be any swings in the pressure, but because of this small amplitude which we are giving on tidal volume, there might be mild swings in the alveolar size, and then that will give less than dead space tidal volume. But you will keep the alveolar remains recruited. There won't be any atelectasis or over inflation of the lung alveoli. So here, how to decide how much map to start whenever you're starting the baby on high frequency ventilation. So most of the times we'll use it as a rescue mode. We'll start with conventional ventilation once babies not comfortable or not maintaining oxygenation. So you are going pressures beyond 20 and PEEP of 6 to 6, and you're giving PAP beyond 20 and FiO2 is around 50-60%, then you might go for high frequency ventilation, because now you are more worried about giving more volume trauma, ventilator associated lung injury, because you are using high settings. So with high frequency ventilation, because you have that advantage of using lesser pressure, but using continuous descending pressure of MAP and then lesser tidal volume, so you will go for high frequency ventilation. So whenever using the rescue mode, then you can go based on the whatever baseline map is there, you can increase that map by at least 2 from the baseline map, and then you can start with 2 values above the map on the conventional ventilation. Or if you're using the primary mode, sometimes in extremely premature baby, just to avoid the lung injury, if the babies are less than 29 weeks, babies on non-invasive respiratory support, CPAP, NMV, and then baby failed NMV, then directly also some center they will practice high frequency ventilation just to prevent the lung injury in those babies. So when you're starting as a primary support, then you can start MAP of 8 to 9, and then depending on the baby's compliance, you can adjust your settings. So here, most important in a high frequency ventilation, whenever you're using MAP is using open lung ventilation strategy. So whenever you start MAP two values as a rescue mode, so you know that it is babies having breed high settings, probably underlying parenchymal disease or variable heterogeneous lung disease is there, baby requiring more pressure. So you will start at least two values above the MAP on the conventional ventilation. And then whether recruitment happened or not, that you will guide by using your F5O2 levels. So once the babies, once you start that MAP of 12 above the MAP on conventional ventilation, then if you see that babies F5O2 levels are decreasing, that means babies lungs are like better recruited. So once FIO2 recruitment is decreasing like around 30 to 35%, then you are comfortable. Okay, these babies lungs are recruited adequately. But if recruitment is high, it is not decreasing, that means baby needs more MAP. So you just go on increasing the MAP. So this graph depicts your time and then airway pressure. So once you increase the MAP gradually, once you reach this point of B where that is the critical opening pressure. So once this critical opening pressure means once your effort requirement has decreased to around 30 to 35%, with that pressure means lungs are adequately recruited. So, but then you don't stop there because you're using a higher MAP and might be in the inspiratory slope of the PV curve. So you have to decrease the pressure again to see where effort requirement start increasing again. So this is the critical closing pressure. So here, this is the MAP where lung alveolar again, your effective recruitment has started increasing. That means your again recruitment is happening here. So again, you will note down these critical closing pressures. So now what will you do? Again, you will increase the pressure to the previous critical opening pressure, which is the point D. Again, you will that means again lungs are adequately recruited, but again you will decrease the pressure to just two values, 2 values above this critical closing pressure. So you will not allow that lung to de-recruit again. So just keep it slightly above the closing pressure. So lungs are adequately recruited, and then give some time to the baby. Once after 12 to 24 hours, again baby you will, once you expect that baby is improving or lung compliance probably is improving, then you can start again decreasing the MAP once baby's requirement remains stable. So this is the concept which you use in high frequency ventilation as a part of open lung ventilation strategy. So here, that's the main thing. This is the PV curve, pressure volume curve. So here, both the in conventional ventilation, when we are using, you are using PIP, when you are using adequate inspiratory pressure there, again you will go to the peak part of the PV curve. Where lungs are adequately recruited, but again once you decrease during the expiratory phase, again once baby reaches PEEP, again you will go back to the lower part of the PV curve, where again distension and increase in decrease size of the alveoli will occur. But in HFO ventilation, you will give you here the same concept which you can, during the inspiratory, once you are opening the lung during this inspiratory phase, initially when you are giving MAP, once the lungs are open, then you will go back into the expiratory curve of the PV curve, and then you will keep the pressures here so that lungs are adequately recruited, and then there is better expansion. So here in HFO, you will give same pressure continuously. There won't be any swings during this inspiratory cycle, and then volume will be adequately, adequate delivery of the volume will happen. So this is the basic advantage of HFO. There won't be any swings during the inspiratory and expiratory phase of the cycle by using constant MAP, mean airway pressure. So one more advantage of using this adequate MAP is there will be, in addition to avoiding this ring, there will be decreased improvement of the VQ mismatch. So because you are preventing this collapse of the alveoli, and also you are avoiding the over distension. So once you reach this critical opening pressures, always you try to decrease the MAP at least 1 to 2 values below, and then try to continue ventilate the babies during this either recruitment or a mild distension, but not over distension. So with the optimal VQ match, then better baby will have better oxygenation and saturation parameters. So you want better recruitment, but not also over distension. Once compliance improves, you should start decreasing the MAP. So that is also most important thing which you should consider. So you don't continue the MAP continuously for prolonged time. Once baby is stable, try to decrease it early. So one more parameter which will decide on the most important parameter is amplitude or delta P. So this is a basic thing which you see in conventional ventilation. The difference between PIP and P you will decide your tidal volume, delivered tidal volume to the baby. So here in a high frequency ventilation, amplitude or delta P will decide the how much tidal volume baby will receive. So here in conventional ventilation, so this is the pressure time where this is a map or PWP, which is nothing but main airway pressure. PWP is nothing but mean airway pressure in high frequency ventilation. So you will give that continuous pressure. On top of that, you will give that amplitude. So once you start pressure of 10 or 12, you usually start with the amplitude around 20 to 30 in most of the babies, around roughly double the map which you start to the baby. So here amplitude of 20 means there will be like forward push of 10 and then backward push of 10. So here if IE ratio is like 1:1, so then here if you are giving 10 map, then it will be like 20 here, and then depending on the TI time, the negative pressures will be less. If the IE time is more, then this pressure might be less here, delivered pressure during the expiration. So this will determine your amplitude. So, but as you see, like the amplitude which was generated at the ventilator. So if you are giving so much of fluctuation here, you are giving amplitude of 10 means that the pressure is changing from like 20 to 5 or 6, depending on the what you are kept as a TE time. So, but the whatever this fluctuation is there, that will not reach the alveoli. That will discuss in subsequent slide. So this is the basic concept of using amplitude. So you will start with at least double the map or around 20 to 30, and then depending on the baby's CO2 values, blood gas after 1 hour you will do, and then depending on the CO2 values, will decide adjust the amplitude. So if you give more amplitude, the delivered tidal volume will be more, and then baby will have better ventilation. So if baby is having higher CO2, you will increase the amplitude, then which will lead to CO2 washout. So so what will happen in high frequency ventilation? Those delta P, whatever is there of which we are giving delta P of 20 or 20 to 30, but it will not reach the alveoli. There will be dampening which will happen during the high frequency ventilation. But in conventional ventilation, it is different. So here basically we'll just discuss with the conventional ventilation. So this is the item and etem, and this is the pressures PIP and P which are there on the y-axis. So here because TI time is too high, here TI time we usually set around 0.35 to 0.4 seconds. So during this if you give very high TI time, then this whatever fluctuation pressures we have given, that will reach the alveolar level. So whatever generated here, that will reach the base of the alveoli, and then this much amount of pressure will be delivered. So there will be tidal volume which around 5 ml per kg will be delivered in the conventional ventilation. But in high frequency ventilation, so here delta P is only 10, and the delivered delta P at the level of alveoli is also same. So that's why delivered tidal volume will be more. But in high frequency ventilation, here delta P at the level of the ventilator or the carrying at the level of piston is very high. Like we start with delta P of 20. Here we are giving delta P of 10 in conventional ventilation, but in high frequency ventilation you will start with 20, or sometimes will rarely will decrease around 15, 16, but mostly will start with 20 to 30. So such a high delta P which we give at the ventilator level, but by the time it reaches the carina, it will decrease. There will be a lot of dampening will happen, and then by the time it reaches the alveoli, it is like minimal delta P will be delivered at the level of alveoli. So that's why that increase in the alveolar distension will be minimal. Delta P which reaches the alveoli is minimal delta P. But here why this happening dampening is because of the very high frequencies which is there in the high frequency ventilation. So here we are using rates of around, at least if you start with frequency of 10, that means you are giving rates of 600 breaths per minute. So here per breath it is just like 0.01 seconds which you are giving for TI time. So during because it is TI time is very short, the delta P which is reaching the alveoli is very small. So that's why like baby will ventilate with a very small tidal volumes. They will reach like just less than dead space tidal volume, 1.5 to 2 ml per kg. So whenever you are keeping this, once you have kept the delta P on the baby, then you have to see the oscillations of the chest. If the around the from the chest to the umbilicus, you will see if the oscillations are reached till the umbilicus, that means you are giving adequate delta P. But always you have to confirm with the blood gas after at least 30 minutes to 1 hour, within 30 minutes to 1 hour. And then depending on the CO2 values, again, you have to adjust your amplitude. So again, depending on the underlying disease, this delta P transmission will decrease. Like if the baby is having increasing compliance, if the resistance is too high, then your delta P transmission will decrease. Or if the compliance is too low, like in with RDS babies, so then the delta P transmission will be more. That means more delta P will reach the alveoli, baby will have more tidal volume, there will be more CO2 washout. So always try to identify the underlying disease what we are dealing with. So whether it is babies having, we are using HFO in term babies with severe like meconium aspiration, or babies having severe PPA, there is heterogeneous lung disease. So in those babies, probably it is different. The resistance might be too high, but compliance might be normal, or it might be more. Or if the baby, if you are using very high frequency, again, because TI time will be decreasing. If you are using high frequency of 12 or 15, then your TI time will significantly decrease, because of which, again, pressure amplitude transmission will decrease. So again, if the amplitude delta P decreases at the level of alveoli, then again your CO2 ventilation will affect. Or if you are using lesser size ET diameter, again, which will lead to decrease in transmission of the delta P, so which will affect your ventilation parameter. So always try to ensure that you are using optimal frequency, optimal size, the ET tube diameter, and then depending on the underlying disease, you can adjust your frequency with to ensure that the delta P, whatever you have said, that is getting transmitted to the alveolar level. So that we'll discuss how to decide on the frequency in subsequent slides. So one more concept is, if once the compliance is improved, so if you are using delta P without VG mode, so once compliance improves, again you have to decrease the delta P, because now transmission is improving. So delta P, baby will have more ventilation, more CO2 washout, which leads to hypocarbia, which itself it might cause complication. So now recent high frequency ventilation, even Dragger has VG mode, where depending on the underlying compliance, as the underlying compliance changes, it will keep the tidal volume constant by altering the amplitudes. So as same mechanism how conventional ventilation, that VG mode works, here once baby's compliance improves, babies requiring lesser pressures, then automatically the delivered pressures will be decreased, PIP. So thereby delta P will decrease in conventional ventilation. So thereby delivered tidal volume will be constant. Similarly, in high frequency ventilation, once compliance improves, so if you are not decreasing the amplitude, then baby will it will lead to more transmission to the alveoli, delta P transmission, more tidal volume delivery, which leads to hypocarbia. So that's why, just to avoid that, even HFO mode has a VG mode. So where you can keep the tidal volume constant, 1.5 to 2 ml per kg dead space volume, and then depending on the underlying disease, again you will decide. If it is normal lung, you can start with 1.5. Babies having severe parenchymal disease, where compliance is more, where you will expect that transmission delta P requirement probably high, then you can start with slightly higher delta P, like 1.5 to 2 ml per kg. Around 2 ml per kg, and then you can start decreasing once baby's compliance improves. So you can set the tidal volume VG, and then you can adjust your settings. So one map amplitude, and the next parameter is the frequency. So how to decide what frequencies to start? So this graphs shows x-axis there is frequency, on the y-axis there is lung impedance. So as frequency increases, so lung impedance will decrease. So there are two components. One is the corner frequency, one is resonance frequency. So these white circles are resonance frequency. That means there is a lowest to this is the frequency at which the lung has the lowest impedance. So that is the lung resonance frequency, and that's the lowest impedance. One more concept is corner frequency. So here corner frequency means there is frequency below which frequency above which the fall in impedance will be minimal. This is too small. So we usually start all the babies on this around the corner frequency. So that means we want that optimal frequency where above which the lung impedance will be fall lung impedance will be small, so that whatever settings we have, like delta pH we have discussed, that will be transmitted to the alveoli, and then also we are giving adequate time to the baby. So usually that depends on, again, if the baby is having healthy newborn, so you will see that coronary frequency is around 10. So around frequency of 10, below which there is a fall lung impedance will be minimal. So you will start with 10 frequency. You will not touch this parameter routinely whenever you are adjusting your ventilatory settings. You will always go for other parameters, like if the ventilation, baby is having ventilation issues, CO2 is high, then you will touch the amplitude, not the frequency first, because this is a resonance frequency which we are using, corner frequency which we are using for these babies. But if the baby is having underlying lung disease, like if the baby is having severe RDS, so where if RDS means there is compliance is very low, so that means again they will require as compliance is or if the baby is having high resistance, like air leak is there, or pulmonary interstitial emphysema, or baby is having severe term babies with meconium aspiration syndrome where the resistance is too high, then babies the frequency will be low. So they usually there is a corner frequency will be around 8. So depending on the underlying lung disease, if you are having increased resistance under airway resistance disease, then you will use frequency of 8. If you are using if you are having baby with compliant lung low compliance lungs like RDS, then you will use impedance. So impedance basically depends on the both resistance and the compliance. If your resistance is more, that means your impedance is also more. If your compliance is less, then it is inversely proportional to the impedance is inversely proportional to the compliance. So if your compliance is less, then your impedance is more. So then you will need you can use, like, even if you're basically if you're using more frequency, that means your TI time is less. You're decreasing the TI time. As suppose if you're using 10 frequency, your time is 0.01. But if you're using frequency of 12, so that means now your frequency is decreasing further. TI time is you're decreasing the TI time. So because your impedance is here more, so then the delta P will be delivered to the alveoli better compared to the healthy term newborn. So it is inversely related to the time constant of the respiratory system. So if you are having any low compliance disease because of short time constant, you can use higher frequencies. But if you are having high resistance lung disease, then you have to use the lower frequency. So that is the optimal frequency where below which the foreign delta P will be small. So this is roughly how you will decide the frequency of 10, 8 or 12 depending on the underlying disease. So basically, once you are using conventional ventilation, depending on the minute ventilation is nothing but the target tidal volume and the frequency. Here, both equally contribute to your ventilation. So if you increase the frequency, again, your ventilation will increase up to a certain extent till the T8 expiratory time is not decreasing significantly. Or if you are using tidal volume, again, your ventilation will increase. But in high frequency ventilation, basically this ventilation is defined by the gas transport coefficient, which is nothing but the dCO2. So if your dCO2 is high, that means baby's ventilation, baby is having better ventilation. So your PCO2 will be low. So dCO2 is inversely proportional to your PCO2. So if dCO2 is high, then your CO2 in the blood will be, percentage of CO2 will be low. So again, this gas transport coefficient depends on your tidal volume square versus frequency. So it's predominantly tidal volume which determines your ventilation in the high frequency ventilation. So if you increase the frequency, these graphs which you're seeing on the screen, so if you're using frequency of 8 versus frequency of 15. So if you're using frequency of 15, the TI time will decrease compared to frequency of 8. So because your TI time is less, again, your tidal volume will be low, significantly decreases. Once, even though you are increasing the frequency, but your tidal volume will be decreased significantly because your tidal volume is almost square proportional to your gas transport coefficient of the CO2. So that's why here, even though you increase the frequency, but because of decrease in tidal volume delivery, babies will have CO2 retention in these babies. So that's why it is inversely related compared to conventional ventilation. So if you increase frequency, then tidal volume will decrease, delivered tidal volume will decrease, so babies will have CO2 retention. That's why we'll always adjust the tidal volumes initially whenever baby is having any ventilation issue. Then if we are after reaching the maximal tidal volume and then maximum delta P, then only we'll go and change the frequency depending on the underlying disease. If the baby is having airway resistance, or if you're using 10 a frequency of 10, but babies have very high resistance, then you can decrease the frequency to 8 for optimal delivery of delta P to the alveoli. Then that will improve your ventilation parameters. CO2 will be better. So as we discussed, with increase in frequency, there will be decrease in the tidal volume, which leads to CO2 retention, which happens. So that's the correlation between frequency and ventilation. So one more parameter which we usually don't touch is the inspiratory to expiratory ratio. So as I have discussed initially, so inspiratory time represents the portion of the respiratory cycle that the piston spends in the forward motion. So that, as we have discussed in the initial slide, the piston move forward. So that will determine how much time it takes for that position to reach. That is the inspiratory time. So usually we'll keep it 1:2 ratio as a norm. So usually give TI time around 33% time, and expiratory time will be around 66%. So that is the ideal ratio which we use. But for some patient, if the babies are having severe underlying parenchymal disease, or we are reviewing the maximum settings, and then babies still babies having both either oxygenation issue or ventilation issue, then you might give IT ratio of you might change the IE ratio to 1:1. So you will give slightly increase the TI time to 50%. Then probably your that might benefit in better recruitment, because your TI time is more. Probably baby will have better recruitment, and also because of TI time is increasing, tidal volume delivery might be better, so baby might have better ventilation. So then IE ratio you can use at 1:1, but most of the time we'll use IE ratio 1:2. But previous ventilators which they used to use, that sensor medics, they usually have fixed IE ratio, that is 1:1. But now newer ventilators, Drager and then SLE, in all these Fabian, all these ventilators, you can use 1:2 IE ratio. So these points we have discussed various parameters. One is mean airway pressure, and then FiO2 for oxygenation, and then delta P and frequency to determine your ventilation, and then IE ratio, which will usually prefer 1:2. So these are all the parameters, and then how to titrate these, that depends on the underlying. For oxygenation to improve, you have to increase the MAP, and then there is both oxygenations or ventilation can be managed separately. So if you want ventilation, you can just change the delta P and the frequency. If you want oxygenation, then you can increase both MAP and FiO2. So if you want to, if baby is having CO2 retention, then you can increase your delta P to increase your tidal volume delivery, and then that will have better CO2 version, and that might help in the ventilation. And then unless baby's delta P is on the higher side, then only you will decrease here. You won't increase the frequency, but decrease the frequencies, which will help in the better ventilation for CO2. So this is how you will titrate the settings. And then, so basic use of HFO, how you will use either rescue mode or primary mode. So most of the times you'll use as a rescue mode. Once baby is on invasive ventilation, you have reached the settings. Previously, we used to wait till baby reaches PAP of 25, but now even once they are crossing 20, we are going for the high frequency ventilation. So once baby is on conventional ventilation, FiO2 more than 50 to 60%, you are giving pressures more than beyond 20 PIP. Then just to avoid that ventilator associated lung injury, you are shifting to high frequency ventilation. So that will give your adequate MAP. You will start with MAP of 2 MBAR above the MAP on the conventional ventilation, and then you will set the delta P as we have discussed, and then this will minimize your progression of the lung injury with HFO, and also improve your recruitment and then gas exchange. But in some centers, mostly in the western side in North America, they are using it as a primary mode, especially in babies who are extremely premature, babies who are less than 29 weeks or less than 28 weeks. They are using HFO as a primary mode. Once the babies are failing non-invasive respiratory support, once they are shutting CPAP, babies failing CPAP, then they are going to NMV. On NMV also babies failing, then babies requiring ventilation, then they are directly going for HFO. in babies who are extremely premature, less than 28 weeks. This is just to prevent the lung injury with the conventional ventilation. So they were starting with MAP of around 8 to 9, and then depending on the baby's FFO to requirement, then we can adjust the required pressures just to recruit in the lungs. So these are the model, but in our center and the most of the centers we are using it as a rescue mode predominantly. Rarely we are using as a primary mode. So these are the overall advantages of the high frequency ventilation. We are using lower peak alveolar pressures compared to conventional ventilation. So here conventional ventilation you are going beyond 20, 22 PIP. So here you are using just MAP of 12 or 13 with severe parenchymal lung disease, and then we are achieving better recruitment. And also ability to manage both oxygenation and ventilation independently. For oxygenation, we are using MAP and FiO2. For ventilation, you are using delta P and frequency. It helps in the preservation of normal lung architecture, and also the ease of achieving better alveolar recruitment and improving the distribution of medications like inhaled nitric acid. HFO, high frequency ventilation, is the best ventilator for delivery of this inhaled medication, especially nitric oxide. So we'll discuss few points about high frequency jet ventilation. So one more ventilation we will not discuss high frequency flow interruption, that is we are not using routinely, or but high frequency jet ventilation is used commonly in some centers, mostly in North America, where they are using. So here basic difference in high frequency ventilation, oscillatory ventilation, jet ventilation is jet ventilation you are using again high velocity jet of gas, you are pushing it directly into the airway, the high pressure and high frequency. So similar to high frequency oscillatory ventilation, here the tidal volume delivered will be low, and also you are using very high frequency but not so high compared to high frequency. So high frequency ventilation you are using around 600 to 900 or 1000 sometimes, but in high frequency jet ventilation you will use around 300 or 400, 300 to 400, 300 to 500 respiratory rate. But again it will just again push the high velocity jet of gas into the airway, where the core of the central core of the airways will be like oxygenated air, which is going through the central core of the airway into the through the larger airways, and then it will ultimately reach the alveoli, and then the expiratory gas will go through the periphery of the airway, and it will go to the outflow outside. So here basic difference is expiration is passive. In high frequency oscillatory ventilation, expiration is also active. So through that piston you are while retracting, it is pulling the air outside. So that is the active expiration which is there in high frequency oscillatory ventilation. But in high frequency jet ventilation, exhalation is passive. So it moves out in a helical flow pattern around the central core of the oxygenated air, and then it will come out. So it helps in the better secretion clearance. So that is the basic difference. So high frequency jet ventilation versus high frequency. Yeah, any question? Sorry. Okay, so I'll continue. Sorry, yeah. Sorry.
कल भी ठीक ही था वहाँ पे.
Please mute.
दोपहर बाद. यहाँ तो कुछ नहीं. यहाँ जैसे था वैसे हो.
So basic difference is, as I discussed, that exhalation is passive, so it moves around the helical pattern around the inspiratory core of the air. So it is basically useful in babies who had significant air leak, like pulmonary interstitial emphysema. So even compared to high frequency oscillatory ventilation in babies who are extremely premature, less than 28 weeks, once they are having this pulmonary interstitial emphysema, air leak, then high frequency jet ventilation is preferred compared to even high frequency oscillatory ventilation, because it helps in the healing of this air leaks, and also it helps in the clearance of secretion. So it has better effect in babies or significant secretions which require frequent suctioning. So here again the concept is same. It delivered very small tidal volumes around 1 ml per kg, 1 to 1.2, and we are using very rapid rates up to 300 breaths per minute. So because we are using too high rapid rates, again here TI time is very less. So here you will set both PIP, peak inspiratory time is very short, around 0.02 seconds, because if you are using 300 breaths per minute, 300 breaths for 60 seconds, so for one breath, it will be around 0.02 seconds. So that is very short. In conventional ventilation, we'll use a TI of 0.35, 0.2, 2.4, depending on the underlying parenchymal disease. So here in high frequency jet ventilation, you are using very low TI time, 0.02 seconds, and you are setting both PIP and PEEP, peak inspiratory pressure and end expiratory pressure. But peak, because you're using very short TI, PIP, the set PIP won't be delivered till the alveoli. So it is for a very short duration of PIP, just for 0.02 seconds. So predominantly T time will be there. So whatever we are giving PEEP, that will be only the will determine your mean airway pressure. So you will keep your mean airway pressures on the higher side, like similar how you will keep in the conventional ventilation. You will start with PEEP of around 10 to 12, and then you will keep PIP slightly on the higher side of 16 to 18. But that will not determine your mean airway pressure. This always peak intensity pressure will determine your mean airway pressures. So this is the flow time, which shows that on the x-axis, this is the time in seconds, and this is the pressure which getting delivered. So whatever here, this is the conventional ventilation where you are giving both PIP and then PIP, sorry. PIP and PEEP which you are giving, but in once you are giving high PEEP, it prevents atelectasis without aggravating the air leaks. So here, because you are using for very short time PIP, and then you are giving PEEP of 5, but once you have to your baby having parenchymal disease, then you will increase the PEEP to around 8 to 10. Which will give you a better mean airway pressure, that will prevent for better recruitment, and also you will give PIP on the higher side for a very short duration, 0.02 seconds. So it is nothing but similar to graph looks similar to the conventional ventilation, but only difference is you will give higher PEEP, and also your TI time will be very short. So because your TI time is very short, so the air leak which is happening from this is minimized. This helps in the better healing of the alveoli, air leak alveoli. So this is just about high frequency jet ventilation, few points, and then we'll just, there are various high frequency ventilators which are available. So this table just shows that there are various ventilators here. Sensormedics, which is the standard standalone high frequency ventilator, but various other ventilators which are there, Drager, Fabian, and then Leone, SLE. So all these, there are hybrid ventilators where you can give both conventional ventilation and also high frequency ventilation with these ventilators. And there is also other ventilator like Bunnell Life Pulse, which is predominantly used for high frequency jet ventilation. So here basic mechanism of generating high frequency is by using the piston Sensormedics, but in Drager and Fabian they use the diaphragm oscillator, which is there, that membrane which is there, that will determine your delta P. It will help in the delivery of this amplitude. And then SLE, the mechanism is by the reverse jet oscillator. So in the expiratory limb, there will be reverse jet which is there, which will help in the delivery of this delta P to the baby. So there are various different mechanisms which are there. And then again, a few studies have shown that various ventilators have there is varies in delivery of these delta P and then pressures. Whatever we have said, the delivered pressures will be different on the babies depending on the type of ventilator which you are using. There are minute variations are also there. So, but these are the various ventilators. They are not kept the images, but these are just names, like one is Sensormedics, Drager, Fabian, SLE, and also Bunnell. So this is a hybrid where we can use both high frequency and conventional ventilation. Sensormedics, you have to use only, it is standard high frequency ventilator. There is no conventional ventilation. And also Bunnell live high frequency jet ventilation you can use with the Bunnell, but again it is, you can't give both conventional high frequency. It is only for high frequency jet ventilation. So exhalation is passive here with this ventilation. So here it is both active and active exhalation. And exhalation is also active here because we are using a diaphragm as oscillator and piston, the other mechanism. So weaning already we have discussed, like decrease mean airway pressure every 12 to 24 hours. Once FFO to recommend decrease to around 30%. So this helps in because lung compliance changes, baby's condition improves. You have to wean your MAP, and then so that you can avoid progressive hyperinflation and lung injury. So again, delta PO amplitude or delta PV is being based on your PCO2 and also presence of spontaneous breathing efforts, and the wiggling is, if it is excessive, then you will try to decrease your amplitude. And then once you can extubate to conventional ventilation, once the MAP is around 8 and then FFO is below 30%, 8 to 9, 30%. And some center they're even directly extubating into room like non-invasive respiratory support instead of trying conventional ventilation before going for the extubation. So here, sorry, this term is not extubation, but change to conventional ventilation, this term. But a direct extubation to non-invasive support is also feasible and it can be done. What are the complications of this high frequency ventilation? So most, though actually this high frequency ventilator came in 1980s, the Henderson scientist had discovered this when he has observed this dogs panting with rapid rates, with very shallow breathing, despite that they are maintaining their oxygenation and ventilation. So he developed this high frequency ventilation. But though it was generated in 1980s, still for many years it was not used routinely because of this worry of these complications. But initial trials which we have done, high-FEE trial, also showed that when they have compared high frequency ventilation versus conventional ventilation, there are a lot of babies who developed IVH, like grade 3 and grade 4 IVH, significantly more in babies who are in high frequency ventilation compared to conventional ventilation. And also incidence of PVL is more. And if you're giving continuously, if you're giving more mean airway pressures, despite improving the improvement in the lung compliance, then those high pressures will transmit to the intrathoracic compartment. Intrapleural pressure will increase. That will decrease your venous return. So basic concept is just you have to use it judiciously. First, try to understand the underlying disease. Start with the appropriate setting, and then always do the monitoring, and then try to come down on the adjust the setting once the baby's condition improves. So this is like that will decrease your incidence of this complication. So now we'll just discuss in the subsequent slides recent trials which are done, which has showed that if you're using HFO appropriately with appropriate settings, and then if you're adjusting the settings properly, then there is no difference in the risk of these complications in conventional versus high frequency. So that's why now we are using it more routinely. So as we have shown, like if there is excessive MAP, if once baby's compliance improves, then underlying lung disease improves, then this pressure will transmit to the intrapleural compartment, which leads to decreased venous return and then decreased cardiac output, and also it will cause increased heart rate pressure and edema. And if again, if excessive MAP, if you are giving it to a normal lung, then it will overstretch the lungs, and then it will decrease the compliance, and also it will increase your pulmonary vascular resistance, PVR, which will affect your VQ mismatch, and then which might lead to worsening of your ventilator and oscillatory parameters. Then these babies will improve once you decrease your MAPs. Then baby's compliance will improve, PVR will improve, and then baby will have better oxygenation. So like sticking onto that high MAP will cause harm to the baby. Once babies improves, then you have to decrease the MAP. And also because of the excessive MAP, there will be decreased cerebral venous return, which might lead to increased IVH. So probably these are the parameters which might have led to more complication in the initial studies when on high frequency versus compared to the conventional ventilation. So this is the largest trial which was done in the UK, high frequency oscillatory ventilation compared to conventional ventilation in extremely premature babies for prevention of CLD. This was published in NEGM in 2002 UK study, United Kingdom oscillation study. So they have used, it was a multi-center study, almost 25 centers participated, and the gestation age 23 to 28 week gestational age babies around, they have in high frequency a randomized trial. High frequency they have 400 babies, and then conventional ventilation they have 397 babies. So when they did the outcome, there is no difference in the death or BPD. And then RR is almost 0.98. So even because now probably people have started using a high frequency ventilation appropriately, judiciously with the appropriate ventilator, then there was no difference in the conventional instance of death or BPD, and also there is no difference in the other morbidities like IVH, serious IVH, and also PVL or instance of cerebral palsy. So even at 2 years of age, there is no impact on the respiratory or neurodevelopmental outcomes of these babies. So this is a largest study of United Kingdom oscillation study. And also they did the long-term outcomes at 11 to 14 years of age. So of these 400 babies, so one center in King's Medical Center, they have with 300 children from their center, they have followed up at 11 to 14 years of age. So of these 160 children in the high frequency group had significantly better small airway function compared to babies who are in the conventional ventilation. So though there are no difference in the like outcomes in the instance of BPD and neurological outcomes, but at long term, at 11 to 14 years, their respiratory functions, smaller wave functions were better. Their forced expiratory flows, it's compared to other babies in the conventional ventilation, or 0.23 difference was there, significantly better. And also other components like even forced expiratory volume in 1 second, forced vital capacity, expiratory flow and diffusion capacity is better compared to conventional ventilation babies. So this is about high frequency ventilation. So evidence, and then we'll just discuss about a few points about inhaled nitric oxide. So this is a potent, selective, and sustained pulmonary it causes pulmonary vasodilatation. It is licensed by FDA for use in term infants with hypoxic respiratory failure or persistent pulmonary hypertension. So in addition to this pulmonary vasodilatation, it also has a direct effect in reduction of the lung inflammation and the preservation of the surfactant function. So just we'll discuss. Basically, inside the body, it is synthesized from the L-arginine by the nitric oxide synthase enzyme. But if despite that, babies on like severe hypoxic respiratory failure, where you are using high frequency ventilation and you have on the maximum settings, you're on maximum MAP beyond 15 to 16, and then you're using 100% FiO2. Then you can use inhaled nitric oxide for that to decrease the pulmonary vascular resistance if there is any underlying pulmonary component of persistent pulmonary hypertension. So this just evidence of this inhaled nitric oxide on clinical outcomes. So this Cochrane review, which was published in 2017, which has showed that in near-term or term infants with hypoxic respiratory failure, if you use INO versus no INO, so there is significant reduction in the death or use of ECMO. Either mortality or need for requirement of ECMO is better. But there is no effect on the mortality, but predominantly it is the requirement of need for ECMO is decreases if you use INO in this baby. So that is the predominant effect, almost 40% reduction in the requirement of ECMO if you use INO. And also in other than this, term babies with hypoxic respiratory failure, other babies like term infant with, if you are using with for babies with congenital diaphragmatic hernia and hypoxic respiratory failure, then there is no difference in the primary outcomes like death or use of ECMO or ECMO before discharge. There is no significant benefit of using INO in these babies with CDH. And also in preterm babies with early onset hypoxic respiratory failure or preterm infants with chronic lung disease or with BPD on very high respiratory support, also there is no significant benefit by using HNO in these babies also. So benefit is only for this term or term infant with hypoxic respiratory failure with use of INO. But the evidence is still not proven till now. So this Cochrane recommends, says there is in this Cochrane review there is reduced INO reduces the incidence of need for ECMO with NNT of 5, and also it improves the oxygenation significantly in 50% of the infants when you use oxygen INO. So oxygen index decreases by mean weight of 8.45 and with PaO2 increase by mean of 32.62. So always the combination of HFO and INO is the most effective therapy for infants who fail to respond to the either one. So there is even they have compared this subgroup analysis of INO when they use with OI of 15 versus OI of 25. Where routinely we use start around 20 to 25, but some center they when they started using even before around OI of 15, there was no significant difference in the clinical outcomes whether you start 15 versus 25. And the outcome of infants with diaphragmatic hernia was not improved, and also incidence of disability, deafness, and other side effects with this INO infant developmental scores were there was no significant difference with whether you use INO or not. So finally, it recommends use of INO at an initial concentration of 20 parts per million in the near-term hypoxic or mechanically ventilated neonate with an OI of more than 25. And if they are on high frequency ventilation on a FiO2 of 100%, despite that, if the PaO2 is less than 100, then you can use INO in these babies. This is based on the evidence from the Cochrane. But this latest guidelines, which was published from the Canadian Pediatric Society in 2023, they recommend again, as per the Cochrane also suggests same, recommend in late preterm and term infant with severe hypoxic respiratory failure. So once it is more than 25, Cochrane evidence is there, but we don't wait till it reaches 25, even beyond 15 to 20. Once it otherwise beyond 15 to 20, despite giving optimal oxygenation maintenance strategies, you can use inhaled nitric oxide. In preterm infants and babies with congenital nephropnea, though there is no evidence of benefit, but it is used as a rescue modality. So in premature babies who are on the highest support, high frequency ventilation, 100% FiO2 and very high support, very high MAP around 16, despite that if they are not maintaining their saturation, then you can use as a rescue modality in these babies. So with underlying prolonged rupture of membranes or oligohydramnios, and also babies who are with late onset hypoxic respiratory failure, severe lung disease, BPD with pulmonary hypertension. You can use that as a rescue model. Again, the same applies to the congenital diaphragmatic hernia, where trial of INO may be considered in infant with persistent hypoxic respiratory failure despite optimal recruitment, and there is a echo evidence of suprasystemic pulmonary hypertension adequate, and there should be left ventricular function adequate. So then only we can use inhaled nitric oxide. So these are the indications suggested by the Canadian Pediatric Society. So always whenever you start, before starting INO, always do echocardiography and then confirm the diagnosis of PPHN. Ensure that your left ventricular function is normal and there is absence, there is no underlying congenital heart disease, which is characterized by ductal dependent systemic blood flow. So these things you have to be confirmed, and then only we can start. But if it's not available and echo is not immediately available in the no facility, then at least you can start as a rescue mode, and then you can, depending on that, again you can confirm as soon as possible later. So prior to initiation of INO, ensure that lungs are adequately inflated. You're using high frequency ventilation, giving adequate MAP, and then you correct the acidosis and hypercapnia, optimize the sedation, and then correct you can use optimal developmental supportive care, ensure that baby is not irritable, and then the baby is comfortable, and then correct the hypoperfusion or give boluses if required, and then obtain the postductal ABG, and then depending on the parameter, still baby is having severe hypoxic respiratory failure, then you can go for initiate the INO. So we'll start with INO of 20 parts per million, and then you can see for response. So after 30 minutes, if you see that if the PaO2 increases in the blood gas, arterial blood gas by more than 20, or if your saturation parameters, if arterial blood gas is not available, then you can see the saturations. If it is increased by more than 10%, or even if I would recommend decreases by more than 20%, still you can consider it as a positive response to INO. So you have to give a trial time of at least 60 minutes, minimum 30 minutes, and then maximum 60 minutes to see the response. And then once if the response is there, then you have to continue the baby on the support for at least 6 to 12 hours. Then you can wean your FiO2 depending on your saturation levels. So once you are telling PPHN, you will slightly target higher saturations, 92 to 96, 97%, to maintain that, to avoid pulmonary vasoconstriction because of hypoxia. So once the response is there, then you will continue at least for 6 to 12 hours, and then by that time you can start weaning your INO, FiO2 levels. Baby is maintaining better saturations. If the response is, when you will say partial response, so if the increase in postductal PaO2 is around 10 to 20, or saturation improvement is only 5 to 10%, or decrease in FiO2 requirement is by only 10 to 20%, then again, if partial response is there, then still you have to give 30 to 60 minutes time, and then leave it on the INO for 6 to 12 hours, though partial response is there. If there is no response, like, sorry, this is less than 10, the postductal increase in PaO2 is less than 10 and saturation is less than 5%, and the decrease in FiO2 recommended by less than 10%, then if there is no response, if you have waited maximum time of 60 minutes, then you can consider the negative response, and you have to directly turn off the inhaled nitric oxide, INO. So when will you start weaning? If the baby has a positive response or partial response, you continue for 6 to 12 hours. And then once you start weaning in the baby, once your FiO2 decrease less than 40%, less than 40%, then you can start weaning INO by 5 parts per million every 1 hour to 5 parts per million. So some centers we are using a 60 FiO2. Once it is less than 60%, you can start weaning. So these are protocol from the
अभी बोला है बताएंगे तुमको.
but you can have your own unit protocol, but roughly around 40 to 60% you can start your weaning of INO till 5 p.m. You can decrease INO by 5 parts per minute. Once you reaches 5 parts per minute, then you can wean depending on the duration of INO support. If baby was INO for more than 24 hours, then you can you have to leave on INO 5 for at least 4 hours. Then you can start weaning 1 parts per minute every 4 hours. But if the baby was on INO for less than 24 hours, then you can wean directly every 1 hour instead of waiting for 4 hours in these babies. You have to wean. You can wean every 1 hour by 1 parts per minute. So once babies are minimum, you can discontinue. Discontinue the INO and then turn it off. But if the when you start discontinuing this weaning, so once you are weaning the baby, but baby if you see that effort again going back and effort increases by more than 20%, and then baby's post-rectal return of pre-rectal saturation or post-rectal saturation by more than 10%, then again you have to stop the weaning, increase the INO by 1 parts per minute until infants returns to the pre-deterioration status, and then you have to continue on that same INO support and the support for few hours, and then again depending on the baby's condition you have to start weaning. So it depends, like sometimes babies might require for prolonged time, 5 days, 7 days INO. So then that's why you have to monitor these babies for toxicity of this nitric oxide, like methemoglobinemia, nitrogen dioxide. So these levels you have to monitor. Once if you like after 24 hours, and then after 3 to 4 days, if you're doing again, you have to monitor every 48 hours. If the levels are more than 5% methemoglobin level, then wean INO by 50%, and if the levels are more than 10%, then it should be temporarily discontinued. And antidotes, you can use IV methylene blue or vitamin C in these babies. So another side effects is the nitrogen dioxide. So this methylene will interfere with the saturation, and one more is the nitrogen dioxide. If stay for upper limit is 3 parts per million, if the levels are more than 3 parts per million, then the dose should be decreased by 50%, and if it is more than 7 parts per million, then you should discontinue temporarily. And then once the levels are better, then again you can decide. Okay, that concludes my talk. If there are any questions, can happily will take.
Thank you, Zaki, for that wonderful talk. I think one of the most difficult and exhaustive topics, because I understand HFO. I think I don't see any doubts, but thank you for emphasizing the concept of open lung ventilation or HFO, and when to consider HFO, especially HFO as a rescue strategy. Just quickly, people normally ask this rule of 20 and 60 in INO. Can you just brief us about that?
Sir?
The rule of 20 and rule of 60, considering the application of INO.
Yeah.
The normal mnemonic kind of thing which we use.
Yeah. So once that babies on INO, that's just like this. What I have discussed here is from the guidelines from the Indian Pediatric Society. So their usage of INO in those babies. So they are using once babies on 40% of FiO2, they are start weaning. Once these babies. So, but here in our settings, we are using 60% of FiO2. Sometimes once babies on PaO2 is more than PaO2 of 60, and then baby's FiO2 requirement is less than 60%, then you can start weaning these babies. 20%.
Okay. Thank you very much. Thank you, Zaki. With that, we move to the last lecture. Can you just stop sharing, Dr. Zaki?
Yeah, sure.
Thank you. So I think this is going to be the last lecture for the day, and it will be brief, not that anything new. It is kind of revision of whatever we have discussed in the last 2 weeks. And I think when we talk about the lung protective strategies, there are two terms which we hear, that is VILI, that is a lung injury. But when we say VILI, that is ventilation induced lung injury, now people are telling, is it really ventilation induced or is it PILI? PILI means physician induced. That is, how we use the ventilator, how we apply it for a given baby determines whether we are helping or harming the baby. So to certain extent, over the last 10-15 years, we have seen that the technology has improved. Maybe to begin with, the ventilators were not suited for the neonate, and much of the design and the protocols were more borrowed from the adult ventilation. So that led to a lot of harm to the babies, especially when they were ventilated for long. So with the improving technology and science, the modern day ventilators with these ultra modern microprocessors and the flow sensors, we do see that now the neonatal ventilation is more easy. So with that, it is our responsibility as a physician that we make sure the ventilator strategy which we apply for a given baby should not be harmful. So for that, we have to remember that there is a constant interaction and action happening between the baby and the machine. And this constant interaction should be monitored and should be titrated with the help of the tools which we discussed yesterday in the form of the volume targeted and the hybrid ventilation, which Dr. Sriram had emphasized. And today morning, Dr. Tejo talked us through the use of the graphics to optimize the ventilation strategy. So when we look at any typical setting of a physician bedside with the ventilator and the baby, we have to understand that there are various components, and these components can be what we normally know as Willy. The first thing we have to remember is the fact that the baby is the vulnerable baby. So I think I will not waste much time here. But the atelectotrauma is the most important thing. That is immature lung with surfactant deficiency, with low end expiratory tidal load and low end expiratory lung volume and small FRC. There is a tendency for the lung to collapse. Now we have to remember that the whole lung is not uniform. It is in three zones. Zone 1 is that area where the alveoli are open during inspiration expiration. Zone 2 is that area where the alveoli are open during inspiration but collapse during expiration. And zone 3 where the alveoli are not even open during inspiration and are also closed during the expiration. So when you're ventilating this lung, it is important that the first thing when you're ventilating any baby is to open the lung. And to achieve that opening of the lung, in the previous lectures, we discussed about how do we optimize the PIP. And that is what Dr. Srinivas Mukhi sir told us in the first lecture. That is, how do you recruit the lung? So here comes the concept of using the optimum PIP and the optimum volume. But if your PWP is not adequate, obviously the lung will keep on stretching and again collapsing, and that will further worsen the atelectotrauma. So A, the baby is physiologically handicapped with its surfactant deficiency and immature lung mechanics, that there is a tendency for the lung to collapse, and this is what is called as atelectotrauma. When you're trying to address this atelectotrauma with your ventilator by giving what we call as positive pressure ventilation, we create the other extreme. That is, we stretch the lung too much, and that is what is called as volutrauma and the barotrauma. And this again has been emphasized by Dr. Sriram yesterday in his talk, that how volutrauma is more dangerous than the barotrauma. Then to give or to maintain optimum oxygenation, if we don't use the proper setting of FiO2, what happens? You don't recruit the lung, and to maintain the oxygenation, if you give additional FiO2, we create oxytrauma. And we all know that high amount of oxygen leads to free radical injury, which is dangerous. And then comes biotrauma. Biotrauma means you are using an ET tube which is going into the baby, and any foreign object in the body induces inflammation. Similarly, ET induces the inflammation, it leads to infection, sepsis. So this is where we have to really keep in mind that shortest form or the shortest duration of invasive ventilation is the most important thing. And we also talked about the rheotrauma, because at the end of the day, the ventilator is pushing gas into the baby at certain high flow rates. Let us suppose if your ET is not proper size, it is small, there is lot of leak. The machine tries to compensate for the leak by upping the flows from the ventilator, which in turn will again cause more flow induced trauma. Or when the ET tube is very small, there is increased resistance, and again the flow goes up, and this can also cause by trauma to the immature lung tissue and the airways because of the high flows. And within this rheotrauma, we have to remember that from the circuits, what we see the gas flowing, if it is not properly humidified, it leads to cold gas injury. So these 5 components baby at risk of electrotrauma, and the interventions which we do with the baby with invasive ventilation, barovolutrauma, the oxytrauma, biotrauma, and the rheotrauma, we have to remember. So with this, what is most important is the physician, and that's what I said, our knowledge and our bedside presence and close monitoring will take away. So the easily modifiable thing of all this is the PILI component, that is a physician component, and that is where we try to keep our knowledge abreast with the current developments and also apply the knowledge bedside with diligent clinical monitoring for the baby who's on invasive ventilator. So this graph is one thing which you all remember and should remember, and I'm sure I'm not going to repeat much on this, but the whole point is to ventilate the lung between these two zones, and to achieve this, the two most important things that you require is volume targeted ventilation and PWP. Now, yesterday when Dr. Shriram talked about the hybrid ventilation modes, he said that either the machine is given the option to adjust its pressure to deliver the tidal volume that is desired for the baby. And we all know that the recommended tidal volume to ventilate a baby is usually 4 to 6 ml per kg. So one thing is we allow the machine to deliver that by keeping the pressure variable. So the machine takes higher or lower pressure depending on how much is the compliance of the baby, and this is called as a volume target ventilation. Second way is you use the pressure to open the lung and you monitor the tidal volume with the chest rise. If the chest rise is good and the delivered volume is fine, then you adjust the pressure manually. So this is called as a pressure control ventilation. Whatever modality we use, whether it's a pressure controlled or the volume targeted, ensure that we keep an eye on the tidal volume delivered. You are giving good tidal volume, but your PWP is inadequate. Then again, the problem comes. What is the problem? The lung is stretching to the two extremes. So that is why to prevent the lung injury, we don't want the lung to go in this zone. We don't want the lung to go in this zone. We want to operate on this. And for that, we have to open the lung with adequate tidal volume or pressure and keep that lung open with a proper PWP. And these are the most essential important component. If at the end of the whole lecture series, you remember that the aim of the neonatal ventilation is to open the lung and keep it open. If there is one message we have to always carry with us bedside is the tidal volume adequate with a normal PWP. And that is what is the crux of the whole aspect of the neonatal ventilation. So I will just focus on the practical aspects. First and foremost is the optimal PWP. So when we set a ventilation or we are starting a ventilation or monitoring ventilation, always keep an eye on the PWP. PWP, which is adequate, we know currently there are limitations in how to assess an open lung, but simple bedside tool is retraction should not be there. B, if you have a chest X-ray, which was done at the point of intubation, see what were the lung spaces. This again will take in hands-on workstation, but optimal PWP. Second, synchronization. So obviously the current era of neonatal ventilator, everyone uses either SIMV or assist control. The aim is the baby and the machine should be in sync for inspiration expiration. And to achieve the synchronization, you should have a good flow sensor which is suited for the baby, and keep an eye on how to use this. Again, this we will be discussing in the bedside workstations, in the hands-on workstations, that how to use a flow sensor properly. Then targeting volume, which I just talked, that always monitor the tidal volume delivered. In the pressure control modes, we set the pressure, but the machine also gives you that I am giving this much of tidal volume, and that should always be limited between 4 to 6 ml per kg. And after the acute phase, as the baby is trying to settle, switch to the hybrid mode, and that is what was discussed by Dr. Shriram on the volume guarantee ventilation. And this is the strategy which works well. So select a mode which is synchronizing with the baby, either SIMV or AC. Set pressures which deliver tidal volumes appropriately by monitoring chest rise and keeping an eye on the VT delivered by the machine. Once the acute phase is over, you have given surfactant, baby is settling, switch over to VG, and this is the best way we can manage most of the RDS ventilation which you require. Third, the ET should be of proper size with proper position. We might have best of the ventilators, we know have all the knowledge, but whatever you intend to deliver and give to the baby is through the ET. So if your ET is of not proper size, it is leaking, it is too small, it creates resistance, then the intent gets defeated. And ET position. If the ET position is too up or too low, then also the ventilation will not be appropriate. So always keep an eye on how the ET, which ET size and how it is fixed and it is properly positioned or not. Then comes vomidification. If you are doing ventilation without vomidification, then you have the biggest problem is the gases injuring and you end up giving longer duration of ventilation, and I'm sure cold gases injuring the lung leads to the worst outcomes in the form of the BPD. And currently the vomidification is external, that is in the circuit, and we will see in the workstation. But the science is so fast that the latest generation ventilator, we have inbuilt vomidification system. So that means the gas comes out of the ventilator at a body temperature with proper humidity, and who knows, the whole circuit with this extension thing will disappear and we'll have a simple circuit delivering vomidified gases. And lastly, preventing VAP. If you do everything well, but you are not maintaining asepsis, you end up giving pneumonia to the baby in the form of ventilator associated pneumonia. And here is the most important teamwork, because again, as I'm saying, you know everything, but you are not doing suctioning properly. And this is one more point which we'll again discuss in the workstation about how to prevent VAP in our NICU settings. Then comes the important thing to monitor the lung injury is monitoring. And this is very important. And this is where our nursing staff, and we should always ensure that we keep an eye on how the baby is. A baby who is fighting the ventilator will injure himself or herself more. So comfort of the baby. If your respiratory support is appropriate, baby will always be comfortable. SpO2. I need not reiterate that point, but the saturation should be targeted 90 to 95%. Respiratory rate. A single most important paramount important point is respiratory rate. If your respiratory support is appropriate, there are no systemic conditions involved, then the RR will be beautifully settling between 40 to 60. If your baby is breathing at 80, 90, something is wrong. Either you're missing something in the baby or your settings are not appropriate. Retractions I already told about, chest rise I told about, timely blood gases. Whenever you make a change in the settings, whenever the condition has deteriorated, a sudden change, gases do help. And gases are aimed at looking at the oxygenation ventilation part and the acidosis. So we should not overdo using the gases, but proper use of gases will help you to know whether you are able to achieve your ventilation oxygenation targets. Again, X-ray to assess the lung volume, possibly, as I said, in a deterioration event at the initiation of ventilation, but definitely we don't do a daily chest X-ray. But when there is a significant change in the course of the illness, then always consider doing a proper chest X-ray. This is not related to the machine or the settings, but these determine that how you minimize the lung injury. Then comes the tricky part, that machine data. There is a lot of details on the machine which we often conveniently ignore. Our main crux is to ventilate, that is to put the ET tube and connect to ventilator, then we forget. But don't forget the trends. And that is what Dr. Tejo told in his talk, that you have to monitor the trend of the baby. The trend is basically shown in the form of the graphs. And this again, we will see in the hands-on workstation that how the graphs look and how we should read them and how to look at the trend. Trend means I might come in the morning 8 o'clock or 9 o'clock for my rounds, but how was the baby from the night 12 o'clock to 8 o'clock? The machine gives me a record. In this, the alarms are very important. If the machine is alarming that inadequate tidal volume, that means either the lung is worsening or there is a leak, you should identify and correct. Because if your tidal volume is not appropriate, then the baby will put more efforts to generate the minute ventilation. And that extra work of breathing will injure the lung. Always monitor the trends. Apart from VT, the minute ventilation, the trend of the compliance and resistance, and C20 by C. All these points have been covered earlier, but my message through this slide is that while you monitor the baby, get the data from the machine to take what Dr. Tejo had very correctly said, an informed judgment, that is to appropriately decide whether you are ventilating appropriate or correctly or not. So while we are doing this whole ventilation strategy, much of this extends beyond ventilation. I need not again repeat this, but if you're timing the surfactant correctly, that to a large extent decreases the duration of the ventilation. Very simple, that once you give the surfactant, obviously the compliance will improve, the pressure requirement will decrease. But if you delay surfactant, so that is why they say if your baby is small, err on the side of giving surfactant timely, because if you delay, obviously the work of breathing done by the ventilator is more, and more is the risk of injury. DRCPAP, even though your baby is born outborn or inborn, earliest CPAP in the delivery room makes a lot of difference. Caffeine, we discussed in the weaning protocols, has a lot of importance. Don't forget the comorbidities, that is appropriate management of PDA, prevention of IVH, and nutrition. Because for the lungs to grow, for the babies, work of breathing to decrease, you have to think of maintaining appropriate nutrition. So in nutshell, the whole lung protective strategy, if we can put it under three baskets, basket A will be our knowledge and our setting on the ventilation. For that, it's very simple. We have to understand the disease pathophysiology, and this is where Dr. Apurva had told us disease specific ventilation setting. And if you remember from Dr. Praveen's talk, where we talked about using the appropriate mode and the modality. So for that, he said that it is useful to use an assist control sometimes in the acute phase. Otherwise, an SIMV also works well. This is basically to make sure that synchrony is maintained. So choosing the proper modality for synchrony and then setting, understanding the disease pathophysiology is the first aspect or the first basket. The second is the care. Care means how you're doing the quality ventilation. So for this, team concept is important. Having a protocol of the unit is useful. We can borrow, we can copy from others, but implement it. And proper monitoring tools. And this is the most important aspect, that we might ventilate, we might have the best of the hybrid and the what you call the automated modes, but still a clinician or the clinical team bedside is very important to monitor. And third thing is the supportive care. And this is where the interesting aspect of supportive care or different components which we take home or which we take to the clinic or to the NICU to implement, so that we don't make the baby suffer on a ventilator. And this is where the pain management, this is where the supportive care, the non-pharmacological measures to decrease the pain, all of them are very important together with the nutrition. So this is what basically the whole story is about. I wanted to keep it crisp because in a nutshell, whatever we have discussed or listened to the speakers in the last 2 weeks, if we implement together, that is where the lung protection starts. And the best way is always ask this question, does the baby require ventilation? If yes, ventilate timely. If no, extubate. And finally, when the baby is not responding, an early rescue HFO and if required INO, as Dr. Zaki has told in his talk, is very important for us to make sure that we don't allow the baby to deteriorate. So with that, I conclude. I know it's a Sunday, and for most of us, this is the only time we get with our family and friends. But thank you for joining and sparing your time. And then still in the next couple of minutes, if you have any doubt, we would be happy to address them. Otherwise, please jot down your doubts. And maybe when we have the hands-on workstation, we will meet on that day. So with that, I think we close the session. Thank you once again for joining. See you all for the hands-on workstation on 8th of this month at Stockholm. We will be sharing the venue details in the WhatsApp group. Thank you.